All right, so Assalamu alaikum everyone. I hope I'm audible to all of you. Am I audible?
Yes, you are audible.
Right, thank you. All right, so in the interest of time, while some more people are joining, we will begin. So I welcome you all to the fifth monthly meeting of Kipro. And before we begin, I would like to invite Dr. Bilal Ahmed for Tilawat of Holy Quran. Dr. Bilal.
Assalamu alaikum. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم اقرأ باسم ربك الذي خلق خلق الإنسان من علق اقرأ وربك الأكرم الذي علم بالقلم علم الإنسان ما لم يعلم. Translation. Read, O Prophet, in the name of your Lord who created humans from a cleansing clot. Read, and your Lord is the most generous, who taught by the pen, taught humanity what they knew not. صدق الله العظيم.
Right, Jazakallah Bilal. Right, so now I am formally beginning the meeting. I will welcome you all to the fifth monthly meeting of Kipro. And I really appreciate all the radiation oncology learners who have joined from within and outside Pakistan today in this session. And I would like to introduce our speaker of today's session, Dr. Syed Furqan Hashmi. Dr. Furqan is our G1 CNS pod lead, and Sir kindly agreed to cover our learning objectives, which were shared earlier on the topic of stereotactic RT in brain mets. And Sir will primarily be covering the patient selection and practical tips. So just a brief introduction of Dr. Furqan. Dr. Furqan is a Sindh Medical College grad from the batch of 2006. He started his internal medicine training and then later switched to oncology in the year 2008. He was the first PR's fellow of the Pioneer Oncology batch of the year 2010. Later, he completed his FCPS in oncology in 2015. He was a fellow with hands-on training in National Cancer Center, Singapore in the year 2016. Later, he served in Atomic Energy Center till January 2018 and joined CyberKnife Tomotherapy, where he served till February 2022. So till the last year, up till now, he's currently working in Sultan Qaboos Comprehensive Cancer Care Research Center as senior specialist and focused on head and neck CNS program with lead in CyberKnife radiosurgery. So this was the brief introduction of our today's speaker, Dr. Furqan Hashmi. And on the screen are our scientific committee members, which includes Dr. Furqan, Dr. Asim Hafiz, Dr. Agha Muhammad Hamad Khan, Dr. Fatma Shaukat, and Dr. Atif Mancha. These are the members of our organizing committee. All right, so in the interest of time, I would like to invite Dr. Furqan to begin with his talk. Sir, I've made you the
Okay, thank
co-host.
you,
You can share your screen.
Okay, thank you, Maria, for the kind introduction. And let me share the screen with you, people.
Thank you, sir.
So can you see my screen?
Yes, we can.
Okay, so Bismillah Rahman Rahim. So today we are going to start a session on whole brain radiation therapy versus stereotactic radiosurgery and brain metastasis. And so basically this session will be based on the learning objectives which were provided earlier to me. And it was quite nice to see how all the freshers and the residents, they can collect and bring this question. And basically, these are the questions which I always face whenever I'm dealing with some of my other colleagues. So it will be new for the freshers who are not involved in the radio surgery, and definitely it will increase their knowledge and their selections uh, for the whole brain radiation versus your tactic. So so this is the center we are currently I'm working in, and so this is the whole list of LORs. There are so many, and definitely I cannot cover in a one session. So I requested if I can do in two sessions. So let me see how many I can cover today in 1 hour, and the rest of us I will be covering possibly next session, and I will be visiting Pakistan next week for 2 3 weeks. So maybe I will be visiting any of the center, then we can cover there as well. So let's start. Brain metastases are a significant cause of morbidity, no doubt, and it has been reported up to 65% of the patient may have this in their course of illness. And luckily, with the improvement and the systemic treatment now, with the better control in the periphery, we are now seeing more brain metastases, and we expect it to see in a future quite a lot. And the possible explanation to this phenomena is definitely because the chemotherapy cannot cross the blood-brain barrier due to it being a sanctuary site, of course. The other sanctuary site is testis. And although it has been postulated that due to the brain metastasis, there is some leakage in the vasculature around the tumor, so chemotherapy may pass. But the issue is to attain a significant therapeutic level of chemotherapy, we need quite higher blood level of that thing. So that's why the classic example is high dose methotrexate. We need quite a high doses for to attain some therapeutic level in the CSF. So previously, maybe like 10 years back, 15 years back, or maybe more, if the patient developed brain metastasis, usually it used to consider usually it was considered as a terminal event for the patient, and the treatment was mostly only limited to whole brain radiation therapy or maybe some supportive care. But with the advent of technology, not anymore. So whenever we are dealing with the brain metastasis, the goal is always to achieve the local control, the most important one. And of course, to improve the quality of life, maintaining the neurocognitive function, and also to improve the local effects as well. Because if the lesion is somewhere in eloquent areas like in motor cortex area and patient is having a motor deficit, of course we have to remove this one so patient can have a better quality of life, and to improve the survival as well as uh, reduction and the elimination of the steroid, because the steroid is the first line treatment, and we cannot keep patient on the steroid all the time. So it has to be reduced due to its long-term side effects. And unless we offer some local treatment, the need for the steroid will keep increasing during the course of brain metastasis, and to minimize the side effect, of course. So there is no doubt is previously, in fact, in some of the patient nowadays, still whole brain radiation therapy is considered as a gold standard. There is no doubt. But there are some issues associated with it. We will discuss about them later. So the good thing about this, definitely it's cheap, readily available. All the cancer centers, almost all the radiation therapy centers in Pakistan, it is available. It can be performed on cobalt, linear, etc. No need of extraordinary equipment. And of course, it can give a quick relief. But the issue is with the whole brain radiation therapy is the doses what we use, like 30 grain, 10 fraction, 20 grain, 5 fraction, is not sufficient to control the disease. Patient gonna progress in 3 months, 4 months, 5 months, they will definitely, uh, except in certain type of histology, which are quite really sensitive, like in germ cell tumor kind of thing, small cell, lung cancer, they are quite radio sensitive and they can respond pretty well with the low dose radiation therapy. But most of the other cancer, like the one we usually face in breast cancer, lung cancer, renal cell carcinoma, they are not controlled on those doses. But another issue associated with the whole brain radiation therapy is the cognitive abilities. So when we talk about it, so the first thing which comes in mind and we always counsel about this is the memory. But to be honest, memory is not the only issue. And we look into the cognitive function abilities. So there are whole list of parameters, whole list of activities which are involved in this. It includes the language, thought, memory, of course, executive function, as well judgment, attention, perception. So many things are involved with the cognitive abilities. So definitely whole brain radiation therapy have an impact on these function if patient are surviving long. And previously, the survival of the brain met patient, median survival was almost 5 months. But nowadays, currently, we are even seeing the one up to 1 year, 2 year. Some of my patients are still following after 2 years, 3 years. And if they have received the whole brain radiation therapy, so definitely these are the side effects. They are quite affecting their quality of life. Even we try to use the hippocampal sparing which associated and if even we associate with some drugs like momentum, it's an NMDA receptor blocker and it's used in Alzheimer disease. Still, 60% of the patient will still face these cognitive issues. So let's jump on our learning objective, and the first uh, objective I would like to discuss is the role of stereotactic boost after whole brain radiation therapy. Because no doubt, when stereotactic radiation came into play in the management, at that time, whole brain radiation was the standard of care. So people have incorporated it. So that's why I would like to discuss this thing first. So RTOG 9508 was a trial and it was randomized control trial. So I would like to mention this one first. And where they compared the whole brain radiation therapy with whole brain radiation along with the SRS boost. So they found there is a local benefit, local control, and the survival benefit. Then what they designed another randomized controlled trial, and they used SRS alone and compared it with the whole brain with SRS boost. Luckily, there was no survival difference, and so that's why people have started thinking whether the SRS can be a standard of care. But the issue with these trials was that they used only limited brain metastatic patient. And the definition of limited brain metastatic patient is it's variable. Some take 1 to 3, some take 1 to 4, some take 1 to 5. I would suggest to take a limited brain metastasis as a 1 to 4 lesions. So now you can see there are currently the trend is going more favorable in SRS, more favorable for the SRS, and the trend of offering whole brain radiation therapy currently is going down. And you can see in this graph, the patient who are getting a focal treatment, the SRS one, are surviving more because of their offered more researches. So the second objective, and this is the most frequent question I've been asked all the time. So is there any number criteria? How many lesions can be treated? How many lesions are safe to be offered radiosurgery? So there is no scientific rationale for selecting number of lesions as the cutoff number for being considered appropriate for SRS. And I will explain you why. And before I give you more details about it, I would like to mention this trial. Unfortunately, we do not have any randomized controlled trial uh, to get any information on more multiple brain metastasis with the whole brain. So we only have this prospective multi-institutional observational study. And this study is currently quoted in most of the guidelines prepared nowadays, whether it's ASTRO, whether it's an ISMO, all the guidelines, they mention this trial, this prospective study. So in this study, they included up to 10 lesions, and but limited the total cumulative volume to less than 15 cc. So I will explain this how this volume works actually. So what they have noticed, so all those patients having a lesions more than more than two, and they divided into 2 to 4 up to 5 to 10 lesions, and they found no difference in between them. So whether they are dealing with a single 2 to 4 lesions or 5 to 10 lesions, there were no difference in their overall survival. So we can safely say, based on this study, although this is an prospective observational study, we can safely say whether the patient is having a 2 to 4 lesion, that is a limited one, or having a 5 to 10 lesions, the survival remains same. The next question which comes in our mind is, what happens if there are new lesions? Will there be increased lesion if we are dealing with higher number of brain metastasis? Or there will be a more repeat SRS or whole brain RT or surgery? Of course, there will always be a chance of developing a new lesions whenever we are dealing with a higher number of metastases. So if you look into this trial, what we can see, the recurrence or the chances of having a new lesions. So this is not uh, the same lesion which is progressing. This is a new lesion which are developing in the far area in the brain. It's almost similar in the both group, whether it's a 2 to 4 or it's a 5 to 10. Of course, in the one lesion group, it is a much lower, but in the 2 to 4 and the 5 to 10, it is still the same. And the salvage as SRS, it is also same in both group, offering a salvage at WBRT is still same, salvage surgery is still same. So based on this prospective study, we can say possibly that we can offer radiosurgery up to 10 lesions safely, provided the volume remains less than 15 cc. So let's talk about how we calculate the volumes and how it works basically. So this is basically Omni calculator. I use it all the time and to just decide about the doses of what we are going to offer. So if a lesion is having a 1 centimeter diameter, so you can see the volume is around 0.5 cc only. If diameter is 2, the volume is 4 cc. And if the diameter is 3, the volume makes 14 cc. This is important to note. So a one lesion, 1 centimeter diameter lesion having a 0.5 cc volume, if we combine the 10 lesions in the same patient, the volume will still be very low, only 5 cc. Even if we combine the 20 lesions, the volume will still be 10. And what we have noticed with experience, if patient is having a multiple metastasis, it's quite frequent to have a lesion around 1 centimeter, 1.5 centimeter. They are variable in size. In fact, with the current utilization of high Tesla MRI, we are able to even localize a 0.2 centimeter lesion as well. So even they are 20 in number, we can still have a lower volume. Here you can see there is a one big lesion having a size of around, let's suppose 2.6 centimeter. It makes up a 10 cc. So it's not a number. It's not a number. Basically, it's a volume that counts more. So what is the impact of margin if we add to this to these lesions? Definitely we need PTV margin. So if any lesion is having a 1 centimeter size and based on the modality available, for example, if when we are dealing with the 7 knife. So we add up only 1 millimeter of the margin because it's based on the accuracy and the quality checks. So we add only 1 millimeter margin around it. So it makes around 1 millimeter here, 1 millimeter here. So 1.2 cc of 1.2 centimeter size in total. So still the 1 cm diameter size, which makes up around 0.5 cc, it converts into 9 cc if we add a 1 millimeter margin. But if we are using some other modalities, other equipments, like if you are doing VMAT, and if you are not using a strict immobilization, we have to use 2 millimeter margin. And adding 2 millimeter margin, it makes around 1.4 cm. And the volume of this is 14. So now, if we are dealing with non-dedicated SRS system, VMAT like any of the Linux available commercially, and we are giving 2 millimeter of the margin, even 1 centimeter lesion can give you a higher volume, and definitely will affect the dose delivery and more doses to the normal organs, normal tissues surrounding. So dedicated system or the non-dedicated system, definitely it makes an impact. So you can see this is an example of one patient having around 5 to 6 lesions. They are quite far away. We used only 1 millimeter of the margin, and we were quite safely, we were safe to deliver the radius surgery. So this is one example of the patient, and she was basically a very young patient, around 25, 26-year-old, triple negative breast cancer. All the chemotherapy options were done. She cannot afford any kind of immunotherapies, and already received whole brain radiation therapy. So this image which you are seeing is after the whole brain radiation therapy. So no option was left. She came from all the way from Peshawar to Karachi, and we were left nothing but to offer something. So I did a radiation surgery. It was a fractionated one. Could barely manage to deliver 27 gray in 5 fraction. And so this was the result. It was a partial response in the biggest lesion, and the smaller lesion were all gone. Of course, the systemic disease was progressing, so patient could survive at 7 to 8 months after the radiation surgery. So in total, from the start of diagnosis till her death, she survived around 10 to 11 months almost. So what are the organ risk constraints using brain metastasis? Well, so I'm talking about this organ, this learning objective. So basically, when we are dealing with the single fraction radius surgery, and we take V12 and the V14 parameters, we always try to achieve V12 less than 10 cc, and this is basically a cropped GTB from the whole brain, and we try to achieve this. And second parameter is a V14. It's a 14 gray dose delivered to this much of the volume. So we try to achieve it 7 cc. We always try to achieve both in a one patient. If we cannot, at least we follow V12 one. And the chances of developing a grade C toxicity, which is a radionecrosis, is less than 10%, in fact 5%. And of course, it depends upon how much the volume is close by. If it is multiple lesions, are they overlapping their volumes or no? If it is a single lesion, if it's a big enough. So it all depends upon those things. So in case if we were unable to match these parameters, then of course I always prefer to fraction it, and I use the TG101, as well as now we have high tech as well. And basically it's radiologically derived from this B12 volume. So we have an option of treating those patients in a 3 fraction or the 5 fraction. And in the 5 fraction, we take V29 basically. So V28.8 or V29, just a same thing. We take this one, or we take 3 fraction, V23. So in this example, you can see this patient is having a multiple metastasis and his V12 may not be achieved, just for example. So in case if it is going above, what we see that how far the lesions are and whether they are low dose isodose is like 10 gray isodose, are they overlapping or no? If they are not overlapping, we are safe to go even if the V12 is exceeding. So this is one more example. It was a 2.8 centimeter diameter lesion. And what you can see, there is another lesion with almost the same size, but their volumes or their isodose lines are overlapping here. So if I'm having this lesion only, I could have offered a single fraction, possibly with up to 18 gray. But because there was other lesion very close by, and in fact their isodoses are overlapping, so I fractionated this lesion, and I preferred going with the 5 fractions. Another example, and lesions are quite away, but not enough for us to achieve the single fraction doses. So I fractionated here as well, 5 fractions. So another learning objective, who are the patients that are candidates for front surgery rather than stereotactic radiation treatment? One of the hot topic as well. So currently, the surgery for the brain metastasis is limited. Mostly it is offered if patient is having any mass effect, large, the lesion is large enough, like more than 3. And if there is a uncertainty about the diagnosis or patient is having unknown primary. So in that case, the surgery is preferred one. And if patient is developing metastatic, like metachronous, like after 2 years or 3 years, and having a single focus lesion, so it is also preferred to have a biopsy there. And because with the advent of molecular targets, immunotherapies kind of thing, so we need to determine what are the molecular markers or if there is any actionable mutation. So it is preferred in that case as well. But it is important to know if we are offering us. So can you please turn off the mic?
Yes, sir,
Maya,
I'm
can you
taking
please
care of
check?
that. Yes, sir, I'm taking care of that. You please continue. Thank you.
Okay, thank you. Okay, so solitary lesion with a controlled systemic disease, the aim should be a maximum debulking. It's not like just going and taking a small biopsy if you are offering a surgery, especially. It should be aimed for the total surgery, total gross tumor dissection, because if you're leaving behind 50% of the tumor behind, it's not a good thing. We can accept a partial resection or the debulking only in cases that there is a mass effect, like a midline shift, tumor is pushing brainstem. In those cases, we can accept the partial debulking. But in the supratentorial region, it's always preferable to do a total resection. And if you cannot do a total resection, it's better you leave it, unless there is a massive. So these are some practical tips I experienced, and especially if the lesion in the posterior fossa or the large cerebral met, and they tend to develop hydrocephalus if you are doing a radiosurgery. So if they are large enough, it's better to do a surgery first. If not, surgery cannot be done like a patient refusing, which 90% of the patient I have treated, they always refuse this thing. So at least offer them a VB shunting if there is a D-shaping of fourth ventricle. And even they are refusing this thing, just counsel them that this VP shunting might be needed in the future. Cystic mat or the big necrotic core, these patients tend to have a very poor response. So if any lesion is having a 3 or 4 centimeter size, and if it's a solitary as well, rather than offering radiosurgery, it's better to offer them a surgery first. So is there any size criteria? No, unfortunately, there is no size criteria. But as a general, what we do in the supratentorial lesions, if it is a solitary lesion And if it is more than 4 centimeter size, it's preferred to have a surgery, debulking, total resection. And in the posterior fossa, because there is no space, and even some small lesion can cause a lot of trouble there. So 3 centimeter size in the posterior fossa, and if it is a surgery lesion, better to push them for the surgery. So you can see this is a big lesion around a 3.8 cm uh, diameter. Patient refused surgery. Of course, most of the patient do same thing. We offered a radius surgery here. 5 fraction 1, 30 grade 5. And later on, patient developed a lot of issues. And she was wheelchair bound for a while, but after 4 5 months, she recovered well. Another patient in the posterior fossa lesion, although size were not big, the good thing about this lesion was it was not a necrotic. So when you see this kind of lesion, expect a poor response, or the response will be quite delayed. Like it may take up to 1 year for the complete resolution or even a partial resolution. But for these kind of lesion, when they are enhancing uh, beautifully like this one, no necrotic core, possibly they respond really well. You can see there is one more lesion in the medulla as well. So I fractionated them and they tolerated the treatment well. So if you look into the guidelines like ESTRO, ESCO, SNO, they even in the ISMO, so they do not prefer surgery first unless the surgical resection is for the biopsy or there is a mass effect. So only in those cases. Or surgical resection is recommended when the KPS is at least 70. This is so performance status is a key point whenever we are deciding for any type of treatment, whether surgery or the radio surgery. Performance status is always a key factor for us. So this is one of the patient who received surgery. Actually, it was around 4 to 5 centimeter lesion and solitary lesion. Patient having a controlled systemic disease, and later on she developed metastasis, and she had the surgery in one of the biggest tertiary care hospital in Karachi. And after that, she came to us and we did the scan, and this was the size. You can clearly see how big is the lesion. It's still a residual disease, and preoperatively it was around 4.5 to 5 centimeter lesion. And after surgery, we ended up radiating the 6 centimeter size. So uh, unless they are doing a total distraction, be careful offering a surgery, especially in Pakistan. So when in those trials or in those studies, they are saying a total distraction. So basically they are talking about the European and the American style of surgery, and have being working in Pakistan, you know what type of new surgery we usually have. So be careful when you offer surgery in these patients. Another example, 4 centimeter, 5 centimeter lesion, had a surgery. After 6 weeks, when she recovered and came to us, this was the lesion there. We ended up radiating 6 centimeters. So you can see this lesion around 2.5 cm size, diameter. I offered 3 fraction radius surgery, and after 3 months, it started going down. You can see some shrinkage. And of course, it was a cystic lesion. It will take time, possibly 6 months, 9 months, or maybe a year. It will be reduced. It will disappear. One more example, single focus lesion. We did a radius surgery here, and it was less than 2 cm, around 11 millimeter size. So I did a single fraction, 21 grade. And after 6 months, actually, the lesion was still here. It was an RCC met, so they are quite a residual resistant. So after 6 months, the lesion was still here, but decrease in size. And what we noticed, there is one more lesion. You can see it hardly a 2 millimeter, but because we had a good quality MRI images and we can detect up to even a 2 millimeter sizes. So there was a new lesion, and it was quite away from this lesion. So we safely offered another session. And after around 9 months, there was no evidence of disease. So I followed this patient up to 2 years. Still, there is no disease. So what factors should we focus upon when considering stereotactic RT? So we will discuss about this. So when I was practicing in Karachi, and so mostly we were following this GPA. It's a graded prognostic assessment of scoring criteria. And this is basically based on the age, performance status, extracranial disease, and the number of metastases. And it gives some score based on the performance statuses and the presence of extracranial disease and the number of meds. So if any patient is fitting on the criteria of at least having a score of 3, we offer them radiosurgery. In this score, 1.5 to 2.5, we selectively offer radiosurgery, but almost most of the patient they ended up having radiosurgery. For any patient having this GPA score or having a survival less than 3 months, we never offered radiosurgery. We referred them for the whole brain radiation. So later on, they developed one more prognostic criteria, and it was basically a disease specific. And of course, based on the disease criteria and development of targeted therapy, there is some change, and the more better survival these patients were having. So you see this thing, the renal cell carcinoma, the only indicator or only factor we see in this renal cancer, although it's not mentioned here clearly, the only factor we see in the renal cell carcinomas is the performance status. If the performance status well, these patients gonna do very well on radiosurgery. If the performance status is not good, it's less than 70% KPS, these people are not going to do well on the radiosurgery. Plus, these patients tend to bleed even after the radiation. So be careful offering radiosurgery here, unless there is a single solitary meds. So there is some more modifications in the prognostic criteria, like in the breast, they later on incorporated receptor status, ARPR, as well as the HER2 status. Same happened in the lung, non-small cell especially. They incorporated EGFR, ALK, and some other mutations. So when they incorporated this receptor status, the scoring criteria and the survival changed quite a lot. So later on, we started using these prognostic factors. So any patient who is having expected survival is going above at least 4 to 5 months, we offer radiosurgery. Same is true with the lung cancer. So other learning objective, what new treatment options, especially lung cancer? Okay, we have already discussed here about the prognostic idea. So it is related with the same receptor status. So what new treatment options, especially with non-small cell on the breast cancer, do we still favor stereotactic surgery? So breast cancer patient, unfortunately, even in the presence of positive receptors, presence of HER2 positivity, still we don't have any specific uh, therapy which can give a better result than the stereotactic. So regardless of the symptom or regardless of the receptor status, usually I prefer to treat them upfront. But in case of a non-small cell lung cancer, so we take them as a we look into whether the patient is symptomatic or asymptomatic. If patient is asymptomatic and if they are receptor positive, we delay the radiation. We delay the radiosurgery. If we delay offering any radiation, and if there is any no mutation, and there is a financial issues as well, because no mutations means that this patient possibly be offered immunotherapy, because the immunotherapy doesn't depend upon on the receptor status. It's just a positivity criteria. And so we delay, and in case if there is a financial issue associated with this, we offer radiation. And if patient is symptomatic, regardless of status, receptor status, we radiate those patients. So this is ISMO criteria, and they published recently about their selection. They are taking up to 1 to 10 brain metastatic patient, because if the results of randomized controlled trials, which we saw previously, and that up to 1 to 4 brain patients are doing quite well, and their survival was not different. So it's reasonable to offer even for the 10 patient. We can, because with the advent of technology and all those things, and we have seen the volume criteria especially, and it is safe to offer in them. And especially that Japanese study where they have compared the 2 to 4 lesions versus 5 to 10 lesions, their survival, their recurrence rates almost same. So in fact, they incorporated that criteria in including this patient. So if patient is having a favorable prognostic factor, control extracrine disease, they rather prefer to offer uh, focal treatment, radius surgery, rather than the whole brain, of course. But performance status, if bad, and patient is having uh, uh, multiple brain lesion more than 10, so those patients are offered whole brain region therapy. So dose of brain met near the midline, one of the objective here. And they asked about the brainstem, basal ganglia, corpus callosum. So basal ganglia and the corpus callosum, with reference to brain metastasis, we don't take any specific measures or dose control over these elegant areas. Although they are elegant, but we don't take. And I'm talking with reference to brain metastasis. I'm not talking about the AVM. In AVM, these areas are important, but still we don't have any specific constraints so far. And in the parenchymal lesion, other than the brainstem, we only have hippocampus. We have to consider, but not these areas. So these are treated as like the other parenchymal lesions of the brain. But in the brainstem, we have to take a lot of caution, because the brain stem tolerance is different than the brain. We will talk. We already talked about the tolerance we take about the V12 and the V14 in a single fraction. The brain stem tolerance is totally different, because here we take the max dose as well, the threshold dose as well. So it's completely a different criteria. So do not use the routine radiosurgery doses here. And especially big no to any dose above 18 gray, because we have based on the RTOG study, we select our doses based on the diameter previously, like lesion 1 to 2 centimeter, 24 gray, lesion 2 to 3 centimeter, 18 gray, and lesion above it like 3 to 4 centimeter, 15 gray. But here, regardless of the size, we do not usually push more than 18 gray, because even the sometime even 18 gray is very difficult to achieve. And one more practical point I would like to add: we don't add any PTV margin in in the lesion when we are treating the brainstem, because that PTV margin will certainly add more toxicity. And we don't use any lower isodose lines. Always try to keep above 80%, because of course these brain lesions and brain metastatic lesions, they are always infiltrative lesions. So even if you are seeing any solid lesions, for example here, it will still be harboring some of the normal brain tissue inside it. So if we try to go below these isodose line, we will be increasing more hot spot, not suitable for the lesions like areas like brainstem. So dose below 18 to 16 gray is safer, provided we are achieving the tolerant doses, and 16 gray is most prescribed dose. So most of the time, I only used 16 gray kind of dose only few times, like one or two times only, and I always prefer to fraction it. In fact, so you can see there is a beautiful lesion, 1.3 cm size, right on the brainstem, midbrain, in fact, and it's in the area where most of our corticospinal tracts are traveling. So patient presented with some motor weakness and also having some double vision. And it was because of the third and the fourth nerve compression effect. So I offered a 5-fraction treatment here, and it was a 30 gray. In fact, we used a little or no margin. In fact, it was hardly a 0.6 millimeter margin I used here, because it was not direct intraparenchymal, it was on the surface. So whenever there is a lesion on the surface, you have some liberty. We can give a more doses, like the 30 gray. It was easily achieved here, and because this area will be used as a exiting dose here, and if this area can be used to push the dose away from this side. So this is also a practical point. If any lesion is on the surface, like if having here, so those whichever entering in the brain, it needs some exit area. So if it is on the surface, so this is a safe area where the dose can exit, can control the dose around the parenchyma. The same planning tactic was applied here. So this area was used as a lower doses exit area. So we were quite comfortable offering 30 gray. In fact, so this was the result after 6 months. We cannot see any disease, and her weakness and double vision are resolved. One more patient, quite a big disease, around 2.2 centimeter lesion. And this patient presented on a wheelchair actually. She wasn't having any disease anywhere else in the body, small lesions. And being a logical physician, you can clearly say this patient's performance status that she is on wheelchair is of course due to this lesion. And if we are going to decide based on the performance status that this patient is on a wheelchair, not a good idea to offer radial surgery, it's not logical. So what we tried, we delivered 5-fraction treatment here as well. And we completely counseled that this may be a really toxic, patient may expire even after the treatment. So morbidity did happen. This patient went into ICU after 2 weeks of our 5-fraction treatment, but luckily she recovered. And you can see that this lesion here, after 4 months, it shrank quite a lot. Her symptoms improved. She started walking, in fact. But of course, there were some kidney nerve palsies, and she tolerated. So this was a big lesion, around 3 centimeters. And it's not wise to offer whole brain in these kind of patients. We always counsel, we always explain about the morbidity possibly going to happen, even mortality sometimes. It's patient's choice if they are choosing it or no. I did a 5-fraction treatment here. And after 6 months, you can see the lesion here responded quite well. And of course, it was a necrotic lesion. So it's going to take quite a lot of time to completely disappear. Okay, so as I mentioned, because the topics were quite the LORs quite long enough, I cannot cover in a one session. So, and because definitely you will be having quite a lot of questions after this session. So I just kept my presentation till here, and all the other LORs I will be covering in some other sessions. So far, if you have any questions, I'm open to it. You can ask anytime. And with reference to any of the slide, I'm ready to go and explain again. Thank you.
Thank you so
And
much,
one
Dr.
more thing,
Furqan,
all the pictures you have seen here, they are all our own patients, and we haven't taken any patient any photograph from the internet. So these are all our experience and the pictures. Yes, Maria.
Thank you so much, Dr. Furqan, for this wonderful overview, especially the pictorial references from your own clinical practice were of huge help for our understanding. So I would like to request the participants, if they have any queries, they can just drop it in the chat box so I can take them one by one. And I would like to thank all the esteemed mentors, including Dr. Nadeem Parvez, Dr. Ikram Barni, Dr. Abbasi, Dr. Afia, Dr. Mancha. Pardon me if I am leaving any name. Dr. Asim Hafiz is also connected. I would like to thank all these people who are connected here. You can share your input, and any questions are also welcome.
Assalamu alaikum, Dr. Furqan. This is Dr. Namne Zehra from Shifa International Hospital, Islamabad. How are you doing?
Alhamdulillah.
Thank you so much, sir, for such an excellent talk and very precise, mashallah. I'm sure you are a great physician and a great radiation oncologist. I'm extremely happy to attend this session, and I would like you to invite to our institution. जब भी आप पाकिस्तान आए तो शिफा का चक्कर जरूर लगाएं. Although we are not doing stereotactic radio surgery, but we will be happy to host you and आपको एक टूर दें अपने हॉस्पिटल का और हम लोग क्या काम कर रहे हैं. बहुत खुशी होगी अगर आप आए तो.
Yes, inshallah. If sometime I'll be visiting Islamabad, I will definitely come there. Yeah, sure.
थैंक यू सो मच सर. और दूसरा ये कि आपने बीच में एक स्लाइड दिखाई थी, फ्लो चार्ट था जिसमें आपने दिखाया था कि लाइफ एक्सपेक्टेंसी इतनी हो तो क्या करना है, वो जरा एक दफा प्लीज दोबारा दिखा दें.
Okay. So can you see now this one?
नहीं सर, एक और था उसमें वो कलर्ड बॉक्सेस थे. एक ही स्लाइड पे था फ्लो चार्ट.
This one or
ये
this
वाला,
one?
ये वाला, ये वाला, ये वाला. जी
Okay,
जी,
so
थैंक.
basically I took this one from the ISMO guidelines. You can easily from the website easily.
Thank you sir, it was an excellent presentation.
So
And
do you have any question
I hope
on
we are
this slide?
finding, inshallah.
Okay, thank you.
So thank you, Dr. Furqan. I'm Asim for your such a wonderful and very detailed and comprehensive presentation over the brain metastasis stereotactic radiation therapy. So Dr. Furqan, I have two questions. One is regarding the selection of fractionation. How to select whether we're going to offer 3 fractionation or 5 fractionation. And one more question regarding the fractionated stereotactic radiation therapy, because in your presentation you have shown that there are multiple, the lesion or more than significant in size, and there is also concern about the surgical opportunity on in those cases. So is there any role of fractionated radiation therapy in particular in that scenario? And the other thing is that is more discussed in the literature is regarding the volume of the brain metastasis rather than the number of metastases, because recently there's a lot of paper published, although there's some rather retrospective and the institutional practice regarding the 15 METs or more, or even the more than 25 METs. So would you kindly give your insight or your opinion regarding those volume rather than number of metastases and the dose selection? Thank you very much.
Thank you, Asim, for posting such a question. And for the interest of other people, I'd just like to mention one thing. Asim was my classmate, so in SMC. So Asim, you don't need to call me a Dr. Furqan. You can just call me Furqan. So basically, what happens whenever we are trying to select whether we are going for the 3 fraction or the 5 fraction or the single fraction. So any lesion which is above 3 centimeter for us, and if it is making a total volume of more than 15 cc, I would rather prefer to fractionate. And whether to fractionate into 3 or 5, it depends. If it is just one single lesion with a 3 centimeter of the size, I will fractionate 3 only. If that 3 centimeter lesion is associated with some other metastatic lesion as well, I will go with the 5 fractions. So this is our criteria which we used to follow. And no doubt there is no randomized data, unfortunately, on selections on the number and up to 20 lesions, in fact. But there is a few trials, randomized trial, in fact, going on few are in Canada, some in MD Anderson, where they are following these 5 to 20 patients, 5 to 15 patients. So I think their recruitment has been completed last year, and soon we gonna hear about their experiences. So of course, cumulative volume is a main factor. So for the single fraction, 15 cc max. If you are going beyond that, it's better fractionate. Even with the fractionation, there is a criteria. It's better, you better be careful with when you are having a 30 cm size. It's safe there, but above that, it's a difficult for the patient. Consult them, I explain them about the possible toxicity. In fact, the radionecrosis, and this is something we have seen quite happening a lot. And then in my next session, I will be showing few of our patients who developed radionecrosis and how difficult it was for us to manage them. So I will show them as well. Okay, so 3 cm size with other metastatic site associated with it, 5 fraction. Single focus, 3 cm, 3 sessions. Hope I have answered questions. Any
Dr.
other
Abbasi,
question?
Dr. Abbasi has a comment for you, Dr. Furqan. Very proud to count on you as a mentee since 2007. May Allah Ta'ala give you more barakah in your knowledge and attitude. Well done. Dua go, Dr. Abbasi.
Thank you, Dr. Nadeem. And I would also like to mention one thing. Since my time in oncology, in 2009, when I first met Dr. Nadeem, when he was visiting Piazza at that time. So उस टाइम से डॉक्टर नदीम का मुझ पे हाथ है, और इवन आफ्टर माय ग्रेजुएशन फ्रॉम द पियाज, उस सब की इनसे मैंने गाइडेंस ली कि मुझे क्या करना चाहिए, whether I should be just go ahead with for the FCPS directly or opt for the atomic energy job or what. और इवन उसके बाद भी when I was switching my job from atomic energy, वो सब भी डॉक्टर नदीम से ही मैंने सारे एडवाइस, सारे मशवरे इन्हीं के लिए थे. और इनफैक्ट यहाँ आने से भी पहले, यानी जो भी एडवाइस थे, जो भी गाइडेंस में डॉक्टर नदीम से ली थी. So thank you, Dr. Nadeem, for advising me all the time. It was crucial for my career, and I'm really happy. और ये बरकत है आपकी तरफ से मेरे ऊपर कि जो अभी तक जो है चल रही है मेरे साथ. Thank you.
Okay, no need to say thanks to Allah only. He is the greatest. Acha, one thing is very important. You know, have you ever eaten doner kebab, all of you, and Iskandar kebab and Adana kebab? So, have you ever
Yes.
eaten any kebab without salt? So for us, our Turkish brothers are like salt in food. We cannot survive without them. We cannot enjoy without them. So my humble request to my brothers, Serjan Yilmaz, to give his opinion and his comments, please. And that is why very important for our Pakistani colleagues, please try to talk in English, please, because, you know, we have now international G1 and everybody is joining us. Italians are coming to Karachi for training, you know. So we are intermixing with our Turkish brothers on daily basis. So I think it's very important that we use international language, which is English. So my very humble request, Dr. Serjan Yilmaz, your comments, please, for this excellent presentation by our mentee, Dr. Furqan. So I leave it to you, Dr. Serjan. I stop here. Thank you.
Salam alaikum, everyone. Thank you.
Serjan, I'm sorry, I did not notice that you are here. Otherwise, we have kept on continuing on English.
That's
Sorry
okay,
for that.
brother. Thank you very much. Dr. Abbas, we all, I think, like doner kebab, and we are all salt and kebab itself. Thank you very much. It was
Except coriander.
Nice. Of course, exactly. So, Dr. Furqan, thank you very much. It was really excellent presentation, and it's a really very good opportunity to work with you and learn from these really deep skills. Thank you very much. I learned a lot, and in future, inshallah, we will work more. Thank you, and thank you other participants. Thank you very much.
Thank you, Sajan. Sajan is one of my colleague. He's always involved with me in radio surgeries. So basically, we two are always working together on all the radio surgery cases.
Yeah, thank you, thank you. Dr. Abbas, also thank you. Thank you for nicely
Teşekkür
Ben,
ederim.
ben teşekkür ederim. Jazakallah khair. Thank you very much. Shukran, guys. See you. Bye.
Thank you so much, Dr. Sarjan, for connecting. It was really an honor. Is there any other question?
Thank you.
Or we would just like to move towards the vote of thanks then?
Can I
Any-
just say,
So just in case, if anybody has some questions, just write them down and send to Maria or somebody else, so I can include in the next sessions or learning objectives, and I can explain it in more details.
thank you very much, Furqan. It's Ikram here, Ikram Barni. May I congratulate you for an excellent presentation, and just to say that it was really a lot of learning for me as well. Thank you very much. Well done.
Thank you, Dr. Ikram.
Thank you, Dr. Ikram, for joining. Thank you. All right, so whoever has any queries, they can mail their queries on this email address. And now may I please request Dr. Nadeem Parvez to give the vote of thanks. Sir Parvez, are you here with us?
Yes, thank you, Maria. Actually, I thank everyone for attending this session and for Khan to actually participate in this Kipro. And actually, we always get learning from Furqan while he's here working with us for all the SRS and cyber knife cases. And actually, when he visit Pakistan, I think Karachi is going to go soon. He promised us that he will spend time in Naga Khan with your team. So I thank him for all this and all the people participating and organizing this talk. So I think this is a very good example of the global networking of the doctors around for the help of patient. As Dr. Nadeem Basi said that you can contribute from anywhere now. It's the world of virtual world now. So I think this is one of the good example which Furqan did today and you organize. Thank you very much.
Thank you so much, Dr. Parvez, for your kind words. And thanks a lot, Dr. Furqan, once again for kindly agreeing to address all the learning objectives which we gathered. And I hope to meet you once you are in Karachi. So maybe we can have the second part at that time. If
Thank
it's
Hamad for
suitable for
grabbing me
you.
for this.
Thank you so much. And thank you so much to all the participants and all the mentors for connecting. That's all from my side. This meeting is recorded, and whoever who cannot join, and if anyone wants to visit back, I'll be uploading it on the channel. And you are welcome to share your learning objectives on this email address. Thank you, everyone. Allah Hafiz.
Allah Hafiz.
Thank you.
Abdul Rahman, we can just end the recording.